My name is Robin Galleen and I'm the Mayor of Horsham Rural City Council. I would like to welcome you to tonight's COVID vaccine live Q&A with Dr Rob Grenfell. Dr Grenfell is a registered medical practitioner in public health specialty, general practice specialty with the AHPRA, Australian Health Practitioner Regulation Agency. Rob has over 25 years of GP and public health experience. He has developed and implemented regional and national immunisation programs. He has also developed and coordinated GP and community level immunisation programs. Welcome, Rob, and thank you for taking the time to join us tonight.
Thank you so much, Robin, for this opportunity to speak to the community tonight and probably actually take people through the journey of this virus, and also attempt to answer a lot of the questions that people have got. And I think through my talk, I'll probably answer many of the questions that people will be asking. And again, thank you so much for those that have already submitted their questions, and also for those who will be submitting their questions through this talk. And you can do that in the Q&A session. So again, too, Robin, I would like to acknowledge the traditional owners on this land that we're speaking on today, and pay my respects to the elders past, present and emerging. I was very fortunate to grow up in the Wimmera and to also be educated here. And after I actually started out as a doctor, a number of years after that, came back to practice here in Natty Muck, where as a GP and a public health physician, I was engaged in, as Robin said, a number of the immunisation programs. One figure that I want you all to remember and to be proud of is that in the late 90s to the early 2000s, we became the most immunised area in Australia and held that title for 10 years running. And importantly, even in some of the hard to reach groups and the Indigenous groups, we achieved up to 100% actually adherence with the childhood immunisation schedule. So something that we should be really proud of in this region, and something we held on, and something that I think you actually need to consider with regards to, as we talk through where we're moving with regards to this virus. Now this is I'll share my screen and bring through to you. Here we go. So, bang, we're now sharing. So this is a picture of the virus itself, and this is the sample of the Wuhan 1, which arrived in Australia in January of 2020. And this virus itself was grown in our laboratory, that's Cyro's laboratory down in Geelong, and allowed us to start working on candidates that would in fact get us out of this problem. So this, of course, actually created a great degree of pandemonium, and most of us actually panicked to a large degree and emptied our shops of particularly things like toilet paper, in one sense, pasta, rice, and a whole range of other things. And the chaos that it's actually caused in our community over the last number of months has also been insurmountable. One of the big questions everyone asks is, where did this virus actually come from? Now, the coronaviruses are a family of viruses, and we have actually met some of the really nasty cousins of COVID-19 in the past. Now, SARS came out it was certainly in Singapore and Canada back in the early 2000s, and it was actually very nasty. It had a fatality rate of 25%. That is, a quarter of people who got it died. And it was actually controlled over a very rapid period by isolation. MERS was even worse. Now, MERS actually appeared coming out of the Middle East, but certainly created a great degree of trouble in Korea, in South Korea, where it had a fatality rate of up to 40%. So really, really nasty. So COVID-19, when it appeared, was something of a family of viruses that we already knew about. Now, this is a class of viruses that come from animals to humans. And it's important to reflect that so many viruses that actually affect us come from animals to humans. Influenza is one of those. And influenza comes certainly amplified in chickens and pigs. So hence the reason why we have avian flu or swine flu as examples. And bats alone as well. Australia has had the Hendra virus, which has affected horses and certainly people in contact with those. And there are many other things that actually come from the animal space, and most of these are the emerging diseases. Now, some of the things that we've learned, many people say, well, not many people seem to get that sick from COVID. Well, the answer here is that around about 80% of people will get a mild or moderate disease and look like they'll actually get over that. So what I will do is talk about the clinical course, that is what actually happens to you when you catch this. And I guess this is also emphasised in this recent case of the couple that travelled from Melbourne up to Queensland, is how could they have done this without actually knowing they were sick? Well, apparently what's already coming out of that is that they were not overly sick when they arrived, and they actually got sick a little later, because it takes up to around about 7 to 14 days to get sick. The bad part here is that you're actually infectious before you're actually symptomatic. That's a problem, which is why this virus is a particular challenge for us. Again, think of the flu. The flu, you catch it and you're usually sick within 2 days, and you're spreading it in 2 days, and it's fairly obvious, but COVID is not like that. Then after another week or so, that's when the severe disease can start. Most people may go on and resolve from that point, but around about 15% go on to become severe with difficulty breathing. And what that means is that breathing can get even worse, and certainly after another week or so. And we saw that with Boris Johnson. He thought he was getting better after around about a couple of weeks, and then bam, he actually got worse and ended up in intensive care. And that, unfortunately, is something that actually does occur. And one of the things to note is, what does COVID cause to you, and what does actually, one of the principal reasons that you actually get very sick or die from this is it makes your blood clot. And by doing that, it actually causes disease in your heart, your kidneys, and also your lungs. And a lot of people end up who are in intensive care end up there for around about 2 weeks, which is actually quite a long period of time. Now, that's the problem. If lots of people are getting sick all at once, your hospital gets overwhelmed. And we certainly saw that in many countries around the world. This is the evidence from the American studies. Now, America has, of course, got the most reliable data for us to make judgments on what actually has happened. But what's important here is, in 2020, COVID was the third leading cause of death. Now, remember that heart disease is a multitude of diseases, from strokes to heart attacks to heart failure, and cancer is a lot of cancers. So COVID as a single cause was, in fact, the third leading cause of death in the US last year. Now, that is, in fact, actually serious. Now, the other thing that's serious is this thing called long COVID. And what's becoming apparent is that around 1 in 3 people who catch this virus will suffer for months. And here's what we know so far. That is that they may have chronic fatigue that goes on for many months. They may have trouble with their taste and sense of smell. They may also have a number of troubles with their lung function, and also there are some neurological problems that are coming through, or even persisting depression. So this is not a disease that anybody really wants to catch. It is not a mild disease. And again, I emphasize, none of us have actually had this infection before. With a flu, we've had a variant of flu before sometime in our life. We have never had this infection before. So this is new for us. And so it is likely that when we catch it, we will get the disease, and we may end up with long COVID. Now, long COVID as well, sadly, can in fact persist in people who haven't got that sick when they've caught it. And we don't quite understand why that is. What is certainly clear is it appears that the vaccine will actually reduce that long COVID as well. So that's actually a good thing. But many young people who get mild disease are finding that they are actually having symptoms of long COVID. So when this disease struck, we actually looked at thinking about how we would manage this. Now, the red line on here is what happened in Wuhan, what happened in northern Italy and Spain at the beginning of this. Completely uncontrolled, overwhelmed the community and overwhelmed the population. But when you start to flatten that curve, you actually then run the risk of actually having further cases. But I'll emphasize, the reason why we actually had quarantine, isolation and social distancing was to prevent a surge of sick people overwhelming our hospitals. And I want you to think about what this means for us. By flattening the curve as much as we have in Australia, when we had the major outbreak in Melbourne, our intensive care services were able to cope with the number of cases that came through. And the survival from intensive care was 80%. Compared to New York, when they had their surge, their survival was 40%. That's what a stressed hospital looks like. So we were very fortunate to have actually controlled this virus the way we have. Now, what's going to happen? Well, this virus has decided that it actually likes humans, and it's made that move from animals to humans, and it's going to be staying here. And we're going to have to learn to live with that. And so I will focus a lot on where that actually means. But I want you to carry that on. This virus is coming, and it is going to actually stay here. It's made the jump. So what does it mean? We are going to need to obviously continue looking at lockdown as a way of controlling its spread, and many countries in the world are still using this measure to do that. We're going to need to keep tracking and tracing and quarantining, and we're also going to need to keep doing all of those hygiene measures we've been told about. And the issue of international travel is, well, we will need to keep our borders closed until we're all protected. Okay, so let's talk about social distancing. How does it work? If you don't see a lot of people, you can't spread the virus. And that's in fact actually been very, very helpful in fact curbing it. And this latest outbreak in Victoria has again demonstrated that once you close things down and social distance to a large degree, you can actually bring an infection under control, because people are actually in isolation and are not spreading it to large numbers of people. So uncontrolled COVID, that's the first version or variant of COVID, one person could infect 2.5. The current Delta variant is 1 to 5, so it's much more infectious. And one of those things is I often think about, oh yes, look, the Wimmera. I came back to the Wimmera one because there's less people here and less chance, but who hasn't been to Melbourne over the last couple of months? Most of us. How do you know where your neighbour's been? And many people go in and out of Melbourne. We have lots of transport routes and lots of travel routes coming through. So we are not immune to the virus spreading out of, say, centres like Melbourne and into our community. And New South Wales rural communities are experiencing this now with the case that has actually gone through from Melbourne to Queensland. We think about social distancing as putting pieces of Swiss cheese in front of the virus. So if we social distance, we decrease the chance. If we wear masks, we decrease the chance more. If we wash our hands, we decrease it more. And if we have rapid testing for positive cases and isolate them, we decrease the spread more. So all of these things have to work, not one of them together, to decrease spreading it. And we've done so well in this country in doing this. I always put this one up. I do get a lot of amusement out of the way that people wear their masks, and certainly as it's fairly self-explanatory, a lot of people are not wearing them properly and are certainly not actually getting the full benefit from wearing them. The other thing that has in fact helped us a lot here in Australia is the wastewater testing. As disgusting as it seems, it's actually been very effective in identifying areas where cases may be emerging. So the public health groups have been able to go in and identify those cases. And this has actually stopped a lot of our outbreaks, or at least given us an alert to outbreaks so we could control them. The other thing that's been absolutely disastrous is the travel industry, particularly international borders being closed, has been costing our economy an exorbitant amount of money, and has certainly limited in so many industries in the way that they've actually done that. And by capping our numbers coming back into the country, we've been able to also control the virus and how the virus may or may not impact. Just a little bit about what we've been doing at CSIRO. I have to say the last couple of years have been some of the busiest in my life. We've been looking at evaluating vaccines. We'll talk a bit more about that. We've been looking at understanding the virus and what it is. I'll talk a bit more about that. We had to set up a facility to test masks because so many masks were not actually safe. The wastewater I just mentioned, understanding the virus and how it spreads were other pieces. And this is only a small part of the work I've been involved in over the last 18 months or so. So let's think about what you can do for a virus. You can develop a vaccine, you can develop drugs, and you can develop tests. And the one here that you look at, this slide was made before this pandemic. You look at the development time, normally takes 10 to 20 years for vaccines and drugs, and it's a little shorter for diagnostics. So the question I get asked a lot is, how did we do this so fast? Well, the top part of this shows what we normally do when we develop a vaccine. But I also want to tell you that we actually didn't start this race at the beginning. We'd already been working over the last couple of decades, and my team had certainly been working very closely on SARS and MERS, and other of our research collaborators globally had been working on SARS and MERS platforms as well. And as I said, they are coronaviruses, and COVID-19 is a coronavirus. So really, we actually did have an understanding of things that did or didn't work, and also how we could study a particular virus like this. And so really we were prepared to in fact actually do this. So the other thing where the speed came from, so none of the science was in fact shortened. What actually occurred was doing things in more rapid succession. And The particular areas that slow things down are the regulation and the making of the vaccines. So what changed? We started our studies and we specialize in what's called preclinical studies. So that's studies in animal models. Now, those models, we actually, as soon as we found candidates, and we were testing 3, as soon as we found those candidates worked, those results were in fact handed for those who started the human studies, the so-called phase 1 and then 2 and then 3 trials. Also, the regulators, the TGA in Australia's case, or the FDA in US, were actually getting results of what we were doing so they could start the regulation process and make sure that that actually wasn't going to slow us down. And even more so, the manufacturers got involved to start making it. And in Australia, we're very fortunate to have CSL. They started making both the University of Queensland and the now AstraZeneca, or the Zen Oxford candidate, at an early stage and getting their factories ready to do it. So obviously they're not making the UQ vaccine at this stage, because it has to go back to the drawing board. But that gives you an idea. That's where the speed occurred. A significant focus globally. We were working with a multitude of global partners. This was a true global effort, of which I'm very proud to say we were a significant part of in a number of these vaccines. And this is a pretty picture of the facility down there at Geelong. Very fortunate to have this as one of 6 in the world. So let's talk about the vaccines. This first one, the protein-based, which is what the University of Queensland candidate is like, and they actually produce a spike protein, which is injected, and then your body creates antibodies and an immune response to this. There are 2 parts of the immune response you hear about. One's the T cell, that's a particular white cell, that's the effective immunity against COVID, and the antibodies are also a part of that. The viral vector, which is really what the AstraZeneca vaccine is where a virus that is not harmful to humans is used to carry in the spike protein so that, again, your body produces immunity to the coronavirus spike protein. And this virus dissipates and has no further use. The third one is the mRNA. Now, this is a new technology, and most people say, well, this is really new. I don't know what it does. It's been on the drawing board for the last 15 to 20 years, and we've been watching this as a therapy, and it's been used experimentally in some cancer therapies. And I can tell you one thing, we are, certainly in the medical research area, very excited about this technology, because we may find cures to things like breast cancer, bowel cancer, and melanoma in our lifetimes because of this technology. But where it's worked here is that they found that by putting in the spike protein codes into the mRNA, and then this getting injected into the body, again, produces antibodies and an immune response to the virus. There's a couple of words that everyone's been getting mixed up on, and certainly the press has been making a lot of noise about. Efficacy is the one that you've heard a lot about. That's actually a research measure. It's not really relevant to any sort of comparative performance of any of the vaccines that come through. From a research level, we look at efficacy to say, does it work or doesn't work? If it's actually a nice level of 80% plus, it works. Great. That's all that we needed to know. Effectiveness, I'm going to talk a bit more about that in the next slide, is really how does it work in the population? And that's the one you really need to understand. Efficiency is whether the government's going to pay for the vaccine. Well, that's obvious. This is a pandemic and we've got an enormous cost, so we need to do it. The other one that's creating a great degree of consternation, certainly a greater degree of irritation with me, is this concept of herd immunity. Now, herd immunity is a very, very difficult state to actually achieve. We have sort of achieved that with polio and measles. We sometimes have outbreaks, generally in areas in Australia where immunisation levels are low, but polio, we have achieved herd immunity in this country. We've achieved elimination with smallpox, which is really rare. Now, herd immunity in coronavirus is probably not achievable, and it probably won't be achievable, if it is, for a number of decades. We haven't achieved herd immunity with influenza. We have outbreaks every year, and they vary in size depending on the strain. So that in a sense is something that to me is actually not on the table. The reason we're immunising people is to decrease the chance of severe disease and death. And that's what they're doing, and that's what they've shown they do well. I said I'd talk about effectiveness. Effectiveness relates to how the vaccine was distributed. We know some of these need very cold temperatures, some of these need just cold temperatures. If that temperature is not right, the vaccine may be inactive and not work. So That's the problem. Not in Australia. Our systems are very strong in, and monitored in delivering vaccines, but we've already seen this problem in some countries in the world where their way of delivering vaccines has not been as effective. There are many other areas. So sometimes what we call the host response, that is sometimes if your immune system is not that strong, you may not develop a strong immunity after having the vaccine. And the other one is dense populations. So the virus spreads very nicely in dense populations as opposed to in sparsely populated areas. And the variants, which we will talk about in a second, that actually changes the effectiveness of the vaccines. Now, this is what a map of the variants looks like, very complex, but my team has actually, along with global collaborators, have been following these variants, and we take the new variants back into our laboratory to see if on cell line cultures, whether the immunity is developed from the vaccines that we've already got, and we test this against stored serum that we've got. Now, what's pleasing to say is that we found that the vaccines that we're using here still develop an immune response to these particular variants. And more importantly, in the UK, they have found that anybody who has had the 2 doses of either Pfizer or AstraZeneca are not going to get hospitalised or die from the Delta variant. So that's actually really good news for us. Now, that's what effectiveness looks like, what is actually happening in a country like the UK. So these variants mean, and whilst we still have the disease completely out of control in a number of countries in the world, variants will continue to appear. And it's quite clear that we will need generation 2 and then generation 3 vaccines, probably about 6 months apart until the world situation stabilizes. So we're in for a ride here, and we need to prepare ourselves for that. But again, I'll stipulate, no one has immunity to this virus until they've either had the disease or the vaccine. And the second is you will need boosters of a new generation vaccine or Gen 2 vaccine, as we're starting to call them, in around about 6 months' time. So should I wait for the Gen 2? No, you shouldn't, because you don't have any immunity until you've actually had a vaccine. So there are reasons there, but that's just pointing out where the future's heading. Now, this is the other thing. This is very hot off the press. This is from Public Health England data that I really did want to share. I've launched a release 2 nights ago. Now, the UK is very relevant to us. 1, they have a health system that's really strong like ours. 2, they actually are using the same vaccines that we're using. And so we can see in real time, and they've given tens of millions of doses of these vaccines. What they found is that the vaccines, irrespective, AstraZeneca or Pfizer, are in fact 95 to 99% effective at stopping dying, and 90 to 95% effective at stopping you being hospitalised with serious disease. That is really exciting. From the UK, we're finding that people with the current outbreak of Delta that they're suffering, they've got around about 2,000 or so new cases a day, but no one who's had 2 doses of vaccine is being hospitalised. That is really exciting. So we're looking at an enormous number of savings of lives and also hospitalisations in the UK. So that's another reassurance that the 2 vaccines we've got here actually work very well with the current strains. So let's talk about why would I get vaccinated? And here is obviously a selfie of me getting my first AstraZeneca vaccine. And I want to point out that not only I've had it, my partner, my parents, my brother, sister, sisters-in-laws, cousins, and in fact, my 2 daughters, 122 and 124. And I point out they've had AstraZeneca vaccine. And why? Because I'm going to talk about side effects and the risks of side effects, but it's a very effective vaccine and it's also readily available. Let's talk about why did I have this vaccine. Now, this is American data, and this is very important to actually understand. This is the most accurate mortality, that is death data, for this virus that we actually have globally. One of the important numbers to remember, if you are over 75 and catch COVID, you have a 1 in 9 chance of dying. I'm not talking sick, I'm talking dying. If you are over 50 and you catch COVID, you have a 1 in 90 chance of dying. Not getting sick, actually dying. If you are over 30, you have a 1 in 900 chance of dying. So you can see this is actually a very serious disease. American data is very accurate and certainly can be trusted in regards to how it's been collected. So that's the main reason I had this. I'm over 50, a 1 in 90 chance of dying from this virus, knowing that it will come here and establish here. I don't want to catch it. And We now all know the immunisation schedule. I guess in one sense there's reason for this. The most vulnerable in our community are the most likely to get seriously ill and die from this, which is why we've targeted them in the first instance. And the supply of this has been a problem. One has been hesitancy. So many people say, I don't want the red one, I want the blue one, and all these things. And as I said to you, they are both extremely effective, and I will get to the rate of side effects so that you can understand why I'm actually not as concerned about those side effects as you might think I should be. Because the question is, how long do you want to wait? Because we're already seeing this virus appears to be spreading in this community. Now, what's happened after this outbreak is long queues, and probably most of you who wanted to get it or were vacillating saying, oh, I wish I'd gone and got it earlier. Now, some of the reasons why there's a challenge in getting supply to us is we have a global pandemic and the supply of vaccines is extremely limited. We've been very fortunate to have, one, a manufacturer on shore to make the AstraZeneca vaccine, and two, a reliable supply of Pfizer now that that's actually been attained. And we've got a number of other vaccines that will appear at the end of the year or in the new year. And they will be really used for that Gen 2 variant, as I'm talking about. So the other thing, the reason why we are having challenges here as well in the Wimmera, for instance, is we don't have a ready-made workforce to give us vaccines. So that's all been developed around, and it's been developed over the last number of months to actually get to that speed and to actually deliver this vaccine to the community. So that's some of the reasons. One is the workforce to give it, and the second is the supply. Now, one question a lot of people have asked is, haven't they been sending all the vaccine to Melbourne and we're missing out? The answer is no. The federal government has actually released a number of supplies from their stockpile, which were actually being held for booster doses for people because they're guaranteed they're going to actually replenish that stockpile when those boosters are needed, so that many more Victorians could get immunised at a greater rate. So that's actually the reason why the supply has increased in Melbourne. So it's not actually taking it from us. Let's talk about risk. Now, the figures released today by the Chief Health Officer actually are very reassuring. We have now actually a good understanding about the clot risk from AstraZeneca. The clot risk from AstraZeneca is 1 in 100. Now, that's not dying. To die from a clot from AstraZeneca, we've had sadly two deaths in Australia at this stage, but that's half a person per million. Now, I want you to understand what risk looks like. We sadly lose around about 5 Australians a year to car accidents per 100,000 people. So I said 1 clot per 100,000 from AstraZeneca, 5 people in Australia die in a car accident per 100,000. Now, the death from, which is what we nearly need to look at, from the clot from AstraZeneca, half in a million, that equates to 100 times being killed in a car accident. This is really, really rare. Now, these figures that you're seeing here on the screen are from America. Of course, America keeps better data than most other countries. And I just point out the lightning. To die of a lightning strike in America in 2019 was 1 in 114,000. So we're really talking about something that is really, really rare. And it's unfortunate that people are focusing so much on a side effect like that. And just to point that out, that, you know, you could actually get knocked over by a bus after you've had the second dose. Was it caused by the vaccine or not? I mean, seriously, we have had tens of millions of doses of these vaccines given, and they're already saving tens of thousands of lives. And another way of looking at this clot, if you catch COVID, you have a 1 in 4 to 1 in 5 chance of actually having a serious clot yourself. That's what this virus does. Whereas in the vaccine point, it's actually, I actually worked this one out on the Australian figures. It's in fact actually even far better than that. We're looking at a figure of around about 0.00005. It's much less than the international experience. Now, this has got a lot of words on it, but this came out last night. And this is from the Specialist College of Obstetrician and Gynecologists. Everyone says, what about pregnancy? What about breastfeeding? They have come out last night stating that they recommend the vaccine be administered to pregnant women at any stage of pregnancy. They are suggesting the Pfizer vaccine in this case. and that certainly surveillance around the world has demonstrated from large numbers of pregnant women that there has not been any significant concerns whatsoever with giving this vaccine to pregnant women. And certainly there is no problem whatsoever with breastfeeding. Now, I would urge you, if you've got problems or issues with this, is one, talk about it with your doctor, or look at the College of ONG's website, because this is written down in plain English for you. Now, I thought I might have a bit of fun with you and talk about some of this, because one of the things that's got probably spread far more wide than, in fact, actually the pandemic, for instance, is in fact the misinformation. And I'll just highlight one of my favourite stories that came out in the early phase, that COVID-19 was found on toilet paper. And I certainly threw my arms up in the air and thought, well, everyone's bought all this toilet paper and stockpiled it at home. I hope that this isn't true. Of course, it's not true. So two of my friends, that they're not really friends. One's a cook and the other's a furniture salesman. And I'm actually a public health specialist with, in fact, actually expertise in pandemics. Now, I do take a great degree of offence for people making commentaries on social media that in fact actually are not experts in those areas. I do cook well. I make a lot of nice desserts and also very good on the barbecue, but I don't put that on the internet. And I also restore furniture as a hobby, and I don't put that on the internet either. So why are they putting COVID facts, as they call them, on the internet? So there are many, many mistruths that have been said through, and I will answer some of those because some of those came through in the questions that people pre-sent in. And this really is the frustration that, as somebody who works in the area of evidence, is that people really are making it up and pitching it, and social media has not necessarily been our friend as much in this area. Or more likely put, those of you who can't read the bottom of this, so hey, I know we've dedicated our whole lives to this, but this guy's comment on Facebook raises some interesting questions. I mean, really, what you're reading on social media, you need to ask yourself, really, is that true? How could it be true? What's in fact, who should I listen to, and who's actually got the facts for you? There are a lot of facts. I always put this up. I've been a scholar to pandemics, and the first one that I really enjoyed reading about was the Black Death of the medieval times. There is a happy ending to this, although it almost wiped out the whole human race. At the end of this was the Renaissance, which was the rebirth of human civilization, in the sense of the amazing sort of arts and culture and sciences and other things that actually emerged in the Renaissance. So there is hope at the end of pandemics. This one here is, again, the Spanish influenza. This is a great picture of ingenuity during the Spanish influenza in Japan, which in fact actually wiped out a substantial slab of the population. In Australia, wave 3 hit us very hard and wiped out tens of thousands of Australians. Many Australians took around about 3 to 5 years to actually re-engage with society because of the fear of actually contracting it. And this is actually a really busy slide, but talks about there is science behind pandemics, and there is a lot of ideas about how we prevent and predict them, how we detect them, how we respond, which is where we are now, and the recovery, which I do want to talk about, because everyone says, where are we going? Where are we going? What's going to happen? So let's talk about the future. This virus is coming to this country. It's going to establish itself, and we are going to have to learn to live with it. We cannot live in a state of isolation from the rest of the world. And as we've seen already, it may have even established itself already. But I do believe that we might be able to bring this current incursion under control, but we're not going to be able to do that forever. So we have to get over the idea that we're going to be COVID-free for very much longer. Which means you have no immunity, you need to get that immunity. And there's only two ways to get it. One is to catch the disease, which is not recommended, or the second is to get a vaccine. So what's going to happen? The future, we are going to actually maintain a whole heap of the good hygiene, the physical distancing, and public gatherings are going to be curtailed. Think of how life is in the UK at the moment. That is a good way of looking at it. They have about 2,000 new cases a day. The only people going into hospital are those that haven't had vaccines, and they are still restricted in the openness of their society, but they are still functioning. Sadly, we are going to move into a position like that, or at least a hybrid of that, into the future. Whether it'll occur in the next month or the next 6 months, it is going to occur. And because as the virus enters this country, isolation and quarantine will still persist. And for those of you old enough will remember that we used to do this with tuberculosis. That's just, again, me being the COVID marshal. COVID marshals are going to be part of our life, and they are going to be, in fact, QR codes, and we are going to, in fact, actually be drawn apart from each other. When TB was around in the late 70s, I remember as a school kid at Horsham High, how the TB nurse would come in and do a test on us. They'd always find some kid positive, and then we wouldn't see that kid for a while. And then that kid would come back to school and we'd find out the whole family had been tested. They'd found out that someone in the family had TB. They'd treated them, and they'd waited till everyone else was safe so they could go back to work and come back to school. And we all got a vaccine against tuberculosis at that stage. That type of modelling is going to continue over the next couple of years with COVID. So that will become part of our life, the idea of going and getting tested when we get symptoms to find out if I've got COVID, isolating and working through that. Hopefully we will have some drugs in the future, but there are certainly not many drugs that are actually showing any promise whatsoever in treating this virus. Now, the other thing that's actually also a concern is that many things will have to change. And I did mention after the Spanish influenza that the society did change. People actually avoided each other, and people avoided large crowds and things like this for up to 3 to 5 years after the Spanish influenza. And so we are, unfortunately, going to be looking at how do we deal with crowds? How do we deal with large groups? How do we go shopping? How do we, in fact, actually go and entertain and do a range of other things? And the other problems we haven't seen is that imported goods, particularly those made in some of the countries that have been really solidly affected, like India, for instance, we're going to have challenges with the supply of a lot of essential items. And we did see that through the worst of the pandemic. But what's been happening in India is a great concern for us. So if we think about some of the risk activities, now this is a very busy slide as well, but I'll point to the far right part of this. Going to a nightclub is the worst thing you can do. That's the most easiest way of spreading this virus amongst populations. And there's a whole range of other things that we really like doing, going to church and singing. Singing is a very dangerous thing to do in close quarters with people. Indoor sports, sports stadiums, hugging and shaking people. I guess in one sense, going and doing anything that's actually put you in close contact, and certainly weddings and funerals, unfortunately, are high-risk activities. There are many jobs that are high-risk activities as well. We know that meat workers and certainly in the hospital settings, any jobs where you're in close proximity to other people and you're also exerting yourself is actually a high-risk activity that you're actually involved in. So in those areas, those people in one sense need to be and have been targeted as principal people to get vaccinated in the early stages. So if we think about, say, the aged care setting, for instance, or if we think about, say, a supermarket setting or a setting where people are actually exposed to lots of people in close proximity for a greater than 15 or 20 minutes. Now, if they're immunised, they could have the virus because you can still have it. You don't spread it as well when you've been vaccinated, but you can still have the virus and you can still spread it at a lower rate. But if you haven't had the vaccine, you don't know because they're not sick. And you're actually at risk if you haven't been vaccinated for actually catching this. So you really can't win by actually saying, if I'm not going to take the vaccine, I'll see how it goes. The answer is once the virus arrives here, it's going to circulate and you will be exposed to it. And certainly depending on your age, will depend on how sick you actually get from this. So I've covered a lot of ground for us to actually move into there, and I'm going to actually move now into some of the questions that have come up for us.
Thank you, Rob. That was so interesting. You have answered a few of the questions I'm looking at. So we'll start with a question from Margaret. Is there current evidence to suggest that having 2 doses of vaccine with different types of vaccine, for example, 1 dose of Pfizer and 1 dose of AstraZeneca, is more effective than receiving 2 doses of the same vaccine?
So this story came out, and I have checked this one out as to what's the evidence. This is a study of 600 people in Spain. So at the moment, that study is not very strong. It certainly suggests that you actually can do that, but a study of 600 people is hardly a reason to change what we're doing. And the other thing is the TGA, our health regulator, needs to be satisfied that it is actually worthy of doing, and they will need to have evidence to suggest that they would change what's going on. So at the moment, in Australia, the suggestion is if you start with 1 vaccine, your booster dose is the same as the one you started with.
Thank you. A question from Darren. If you have had a severe ongoing reaction, peripheral neuropathy episode from the first dose of AstraZeneca, is there a process available to request to be given Pfizer as the second dose? I see there are international studies that support changing the types of vaccination taken in the second dose, but this hasn't been approved in Australia. So similar but slightly different to the previous one.
So in consultation with your doctor, any side effects of vaccines are notified through to the TGA. So they are watching and collecting all of these. But in consultation with your doctor, you certainly would qualify for getting a change in the vaccine that's actually given to you. It's always a question of symptoms that actually occur around the time you had a vaccine as to whether the vaccine actually caused them or not. And really that's for your doctor to determine whether or not that side effect was actually due to the vaccine or was coincidental. It's possible that people can get neuropathies from vaccination. Many of the vaccines we use in some people do cause neuropathy as a very rare complication. So again, I'll leave that with your doctor to discuss, but it is possible for you to actually qualify to switch vaccines.
Thank you. A question from Jim. Why is ivermectin, zinc and doxycycline, as recommended by some professors for the treatment of COVID-19, not prescribed by doctors? Is it being suppressed?
The answer is no. No one's suppressing any therapies for the use. The challenge that we've actually had, the challenge that we've actually had with the therapies around here is that none of them have really worked. We've been looking at repurposing and repurposing drugs to see if they do or don't work. There's one antiviral that shows and decreases hospitalisation for 3 days, but that's for a discrete number of people. And one of the steroids that we commonly use is decreased length of stay in intensive care. And the search is going on for medications that will work. Unfortunately, those 3 medications mentioned actually don't work. The idea that some professors, it's questionable, in fact, actually, as to the evidence that they're using. I must say, my colleagues that were working in intensive care trying to save as many lives as possible during the Melbourne outbreak were indeed looking at and involved in global studies to try to see which medications do or don't work. And so many of those that were showing promises in small studies were absolutely ineffectual once they were used in larger groups of people.
Thank you. A question from Martin. How long will the vaccine provide protection? Will I need a booster shot next year? Now, you covered that. Can you just one more time for clarity, please?
Sure. You have no immunity to COVID now. You need to get immunity on that. The only way you can get that is catching the virus, which I don't recommend. And the second is actually getting the vaccine. Now, we have 2 vaccines that work very well against all the variants. Now, they will certainly give you immunity from any of those variants from serious illness, which is what we're trying to achieve. In about 6 months' time, we'll be looking at boosters, and they'll most likely be what we call Gen 2 vaccines. And there are a number of those that are actually already being sourced to be entering Australia into the new year. So my pick is, and certainly many of my colleagues, is that 6 months will be the time you'll get a Gen 2 vaccine. And probably in the next 6 months after that, you'll get a Gen 3 vaccine. And that's until we can control this virus globally.
Okay, thank you. A question from Ian. I have heard that the mRNA vaccines contain lizard DNA. If I get the Pfizer vaccine, will I turn into a lizard?
Yeah, look, no is the answer there. RNA is not DNA, and that's a very important thing to actually stress. And the mRNAs do not contain DNA, and they work at a level in your cells, not in the center of the cell where the DNA sits. And after they've done their job of generating the immunity in your cell, they're gone. And so there is no chance that you'll turn into a lizard at all. But I always often think about the commonality of us with our friends across the biological world. And Robin, I'll just take this a little further. We share 99.9% of our DNA with chimpanzees. And interestingly, we share 90% of our DNA with bananas. So the answer there is that there's not a lot of difference across DNA across the species on this planet, but there are enough subtle differences to make us certainly a little different than a banana, which is a good thing.
Absolutely. We've got a few other questions. When will people under the age of 40 be able to get vaccinated? David's very keen to get the vaccine because he's 36. So how soon will they be able to line up?
Yeah, look, we're seeing a number of states that are actually jumping the gun on this and starting to offer vaccines to younger ages. And we understand that the TGA will be approving the use of the Pfizer vaccine down to the age of 18 soon and opening up to there. Supply is an issue at the moment, David. And the other issue that we've got is we've got to get those vulnerable populations, the one most likely to die from this virus, covered whilst we've got the supplies we've got. As the supplies increase, I'm sure you'll find that is, as in a number of states, that down to 30 will be opened up in the not too distant future. And certainly if they do not control this outbreak in Melbourne, which they look like they have, I'm sure that it was being considered by Brett Sutton that he might have opened up to the 30s and overs as well. But I'm sure it's not far away, and I'm really certainly applaud you for actually being keen to get off the mark. And there are many people like you as well saying, yeah, I'm ready, please. So keep watching.
Great. We've got a question from Leonie. Now, I've heard this one from other people. Is it all right to have the AstraZeneca vaccine if you've already had blood clots?
Look, the answer is we don't really know what the risk factors are that actually mean that you're going to have this blood clot. And most certainly it's not if you've actually had blood clots before, because it's a different mechanism that this is working. It's a really rare mechanism that develops to cause these vaccine-generated blood clots. So the advice from hematologist colleagues of mine, and believe me, I've asked them, I've been working with them on a couple of other drugs that we're trying to look at to use against COVID. They have said that they're recommending the either vaccine to all of their patients. And that in fact actually depends again on what's supplied to you in your age group. So the over 50s, AstraZeneca is recommended. And for the under 50s, we're talking Pfizer, and clots are not a contraindication.
Thank you. A question from Denise. Will I get a reaction each time I have the needle? If so, what can I expect for side effect and how long will it last?
Yeah, that's a great question. So many of us have heard the accounts of people who didn't feel too good after their first AstraZeneca. I was one of those. I had 3 days of feeling a bit like crap, but let's face it, it's far worse than dying. And I understand, and I certainly know that the second dose of AstraZeneca generally passes with absolutely no side effects, if not just a sore arm. And for Pfizer, it's the other way around. The first one, you generally don't have any side effects, and the second one, there are certainly a number of people that are actually having side effects from the second dose. So in answer to that, all vaccines can have side effects, but the vast majority of people have very minor side effects that are managed quite easily with taking a dose of Panadol or something like that.
Thank you. A question from Maxine. Dr. Grenfell, I am concerned about having the COVID vaccine as I have had an aneurysm in October last year. Also, I have other health issues such as migraines, vertigo and asthma. What is your opinion?
Look, again, for your own health issues and your own health advice, discuss this with your doctor. But as a general rule, someone with all those conditions is absolutely essential you get vaccinated against COVID, because the asthma itself is not actually going, lung disease is not a problem, is a problem, but also the other conditions you certainly need to consider, and they're not a contraindication to getting the vaccine.
Thank you. Now, I think this question's a good one. Do I need to take the initial dose to get the booster, or can I just get the booster alone?
Yeah, look, one of the vaccines that's not available in Australia, the Johnson & Johnson's a single dose, and it provides pretty strong immunity with that. So it's not going to be supplied in Australia. What's exciting from the UK is one dose of Pfizer or AstraZeneca will actually prevent you from having a serious disease and getting admitted to hospital in the high 70s to 80%. And also, one dose of either of those vaccines decreases your chance of spreading by up to 65%. So it's actually very good with one dose. However, the lasting, or the immunity, or how long it will last, is not going to be as long as if you don't have the booster dose. And so the booster dose itself gives you more longer and enduring and also stronger immunity. So it is definitely suggested that you have both doses.
So once you have, I've had my first and I'll have my second in August. I assume at some point down the track I'll have a booster. How often how often will we need a boost? Every 6 months, every 12 months after that? What are your thoughts?
Look, the way the variants are going, Robin, I would say that in 6 months' time, you'll be getting a Gen 2 vaccine booster. So it won't even be the same one that you've had at this first time. It's very unlikely that the vaccines, as they're formulated, are what you would receive in that 6 months' time.
But then after that, I'll need one in another 6-12 months, or we just don't know at this point?
We don't know at this point, but the way it's looking, I would suggest that we probably will. And it will be a Gen 3 vaccine. And thankfully, the research goes on. And, you know, we're working with 2 candidates at the moment that I would call, say, Gen 2 and Gen 3 vaccines that would actually provide that effectiveness. In fact, we're working on another one, which is what's called a polyvalent, which will work against a multitude of strains. So, you know, we're not resting. But you will be receiving a different formulation in the 6 months' time, and then in the 6 months' time after that. Think again, the flu, that's reformulated every year.
Yeah. Now I've got a question from Susan. What are your thoughts on allowing a vaccine passport for those that are fully vaccinated so that they can travel throughout Australia without the constant restrictions?
Yeah, please bring it on, is what I would say. The answer there is at this stage that's being debated quite vigorously internationally and nationally as to what it looks like. Once you've been fully vaccinated, we know that you're unlikely to get severe disease. You could still spread the disease, but certainly at a much less state than someone who hasn't been immunised. And really, the problem with travelling is who will let you in and who will let you out. And the border closures around Australia are more a political tool rather than, in fact, a public health tool. So it's a matter of when they will let us into other states. So I hope some sanity comes into this, that once I'm fully immunised, that I can actually travel around Australia. Internationally will be a real problem because, yes, we do have some vaccine requirements on particular diseases already. And I used to manage the travel medicine clinic in Melbourne when I went back to do my master's degree. And the yellow fever is one of those. You actually have to have an authorised vaccine, and it has to be an authorised certificate to demonstrate that you're actually safe to come back to Australia after visiting certain parts of Africa or South America. We used to have vaccine certificates for typhoid and cholera, and we used to have vaccine certificates for smallpox for allowing international travel. I'm suspecting that we will have a passport. Now, it was announced yesterday that we will have that on MyGov and your My Health record. But that also means that you'll actually have to get a My Health record and get access to that, to have that electronic record. So we have got time to work that one out. But yeah, I agree with you. It'd be nice to be able to travel around Australia because that's what I want to do. And I'm sure what many other people want to do as well.
Great, thank you. And I'd like to thank the public for sending in these great questions. And your presentation was just fantastic. I really enjoyed it, very informative. I'd like to remind people that this presentation will be available on the Council's Facebook page where it's been live streamed. We're also going to put it up on the Council's website and Council's YouTube channel, so you'll be able to watch it again or share it with your family, friends and others and encourage them to watch it. So we've got a couple more minutes before we finish up. Rob, is there anything else you think we should just reconfirm for people to allay any last fears?
Yeah, look, we're fortunate in this country that we've held the virus off. So we've actually been living a fantastic time over the last number of months without actually being affected. But those of us that have got friends, colleagues and others overseas know that this is actually real. And the figures I've shown tonight show how dangerous this disease is. And it is going to come here. It is going to establish itself. We don't have immunity. And as I said, there's only 2 ways you can get immunity to this virus. Is one, catch it. And I don't recommend that. The second is vaccination. Be patient about getting the vaccine because the supply of this is being made as readily available as possible. And so the workforce and the supply are 2 things that are constraining that, and they are being addressed. And the reason we're having an ordered and structured program is to try to get to those that would be most seriously affected by the virus first, and then moving through the rest of the population. And we are ramping this up, and that's what's exciting. So, Robin, I think in one sense, I again, would encourage people to seek immunisation as soon as it's available to their age group and age setting, and also maintain all of those other public health measures that we have been doing.
I agree. And not only do I encourage people to have the vaccine, but also to encourage their family, friends, neighbours, and anyone else they speak to who are a little bit reticent and reluctant, and direct them to the council places I just said, the website, the Facebook page, and YouTube channel, where they can check out your fantastic, informative presentation and also hear the answers to some of these questions. So thank you very much for your time. We really value your knowledge and expertise, and being a local boy, it's lovely to be able to have you share your thoughts and experience and that with us. So very much appreciate your time. To those who watched at home, thank you for taking the time to join us tonight. And as I said before, thank you for your questions. So we might say good night. So thank you, everyone. Thanks, Rob.
Thank you.